Hello, everyone. We're going to take a couple of minutes and wait for folks to roll in. I'm also going to have a few little housekeeping things to take care of before we get rolling, and then we will introduce our first speaker, and then a little bit later we'll introduce our second speaker. And hopefully you'll have a lot of information coming your way that you didn't get to have already. Okay. I'm Connie Lee. I'm the CEO of the Alliance to Cure Cavernous Malformation. And today is the first time that we've ever had pediatric epilepsy featured in a webinar that we've offered. So I'm really happy to be able to bring this particular material to you. Just some housekeeping items. After the webinar, there will be a support group, as we usually have on Thursdays. Darla will be running it, and she will drop a link into the chat near the end of the webinar so that when we're finishing up, you can just click on it and it will get you into the support group. And it's always a wonderful opportunity to share with other members and to debrief on what you heard. Then when you have questions, we will have time for questions and answers during this. When you have questions, please do not use the chat. I will not be checking the chat. Please use the Q&A, and you can see that on your screen. Click on Q&A and enter your question. I will be watching and curating those and asking them as the time allows. If your question doesn't get asked for some reason, we will get back to you after the webinar. We know who it is that's asked the specific questions, as long as you don't mark yourself as anonymous. So it gives me great pleasure to introduce Dr. Samuel Ahn. He is an assistant professor of pediatrics in the Division of Pediatric Neurology at UCLA Mattel Children's Hospital and UCLA Santa Monica Medical Center. He specializes in pediatric neurology with a particular interest in seizure disorders. Dr. Ahn, thank you.
Thank you, Connie. Hello, everybody. Good evening. Thank you for inviting me to speak today to the Alliance to Cure Cavernous Malformation. I'm honored to be able to speak today. The topic that I'll be speaking about is about managing seizures. So let's get into it. So just as a general outline, just the scope of the talk, I'd like to start off with maybe just defining epilepsy, the way that we as neurologists and epileptologists define epilepsy. Then we'll get into how we define seizures, different seizure types, as well as the characteristics of seizures, different diagnostic studies that we use to study epilepsy, and different treatment strategies, which may include medications and non-medication strategies. And then finally, we go into a little bit of seizure first aid. Right? So this operational definition of epilepsy is taken from the ILAE, or the International League Against Epilepsy. It's a professional organization. They work hard to be able to define epilepsy in order to better inform treatment. So epilepsy is a disease of the brain defined by essentially any of the following conditions: at least 2 unprovoked seizures occurring more than 24 hours apart, or 1 unprovoked seizure and the probability of further seizures based on additional diagnostic testing, with that risk being at least 60% over the next 10 years. So how do we define seizures? So seizures are defined by multiple different ways, but the framework by which we try to understand seizures first starts with their onset, meaning where did the seizure start? In general, there are 3 kind of patterns of onset that we may be able to see. First is a focal onset, meaning that a seizure may start from one region of the brain, and it may stay within that region or spread. And once it spreads, it may become a bilateral tonic-clonic. Seizure onset may be generalized, meaning that the entire brain starts the seizure at the same time. There's also an unknown onset where we are not able to accurately delineate whether a seizure starts in one focus or starts in the entire brain at once. But in better understanding seizures and focal onset seizures, we can further characterize them by their manifestations, the symptoms that are accompany the seizures. And you might imagine, based on where a seizure originates from, meaning a specific region of the brain, such as the frontal lobe, the parietal lobe, the temporal lobe, or the occipital lobe, the presenting symptoms for those seizures may be different. And we can kind of broadly categorize them as having a motor or non-motor onset. And motor onset meaning that there is some type of movement associated with the onset of the seizure. This can be automatisms or automatic movements of the limbs. It may be a loss of muscle tone, atonic or clonic or jerk movements. But they may be non-motor onset. And non-motor meaning if there's no movement associated, it may affect someone's alertness, someone's awareness, someone's cognition, or their emotion or sensation. Right? And then furthermore, patient may be aware of the seizure while it's happening, meaning they can feel the seizure coming on and as it's passing, or they may be unaware, they may lose awareness where they don't realize that a seizure is happening. All of these little details about the seizure onset and the symptoms associated with the seizures help us to better pinpoint where the seizure focus might be. When we speak of generalized onset, again, these seizures, when generalized, mean that the seizures originate from the whole brain all at once. And these may also be motor or non-motor, meaning movements or without movements. Then again, there's an unknown onset where we're not able to accurately identify where that focus is. Just a few glossary terms. You may have seen some of the older terms for seizures that have been used in the past, such as partial, simple partial, complex partial, or secondary generalized. More recently, and these terms change all the time, we as neurologists, epileptologists, health professionals have been using other terms such as focal aware, or impaired awareness to describe the seizures. I'm going into a little bit of the diagnostic studies. So the gold standard to better understand and diagnose seizures and epilepsy is an electroencephalogram or an EEG study, which many of you may be familiar with, but essentially it's a brainwave study. And EEG is used to measure the electrical impulses that are emitted by the brain. Seizures being a disorder where there's abnormal electrical impulses that we may pick up on the EEG as abnormal patterns and activities. So within EEG, we're able to see the seizure pattern as it's occurring and be able to characterize it. Is it a focal onset? Is it a generalized onset? Are we not able to tell? And we have different lengths of EEG, anywhere from 30 minutes to multiple days. Some other additional diagnostic studies that we use in diagnosing and understanding what someone's underlying reason for epilepsy is neuroimaging studies, such as an MRI brain, which is a detailed photograph and picture of the structure of the brain. It may help to detail any underlying structural abnormalities that may serve as a focus for seizures. Besides the EEG and the MRI, which are pretty standard diagnostic studies for seizures, there's additional testing, more specifically for patients who have tried many different medications and have failed. In other words, have medication-resistant epilepsy. And these are additional imaging studies such as a PET scan, SPECT, MEG, in order to better understand why someone is having seizures. We may recommend or undergo further genetic studies. There may be overlapping neuropsychiatric symptoms or learning disabilities or disorders that can overlap with epilepsy and seizures. Therefore, we have our colleagues in neuropsychology do detailed neuropsychological and cognitive testing, as well as additional imaging studies to essentially better help us frame how much epilepsy is affecting the patient. So going into treatment strategies a little bit, the mainstay of treatment for seizures are anti-seizure medications or ASMs. The main goal of ASMs is to reduce or prevent seizure activity from happening. There are a whole host of anti-seizure medications, 30 plus, that are used for many different indications. There's not always a single perfect right choice or answer of medication for every specific patient. However, we consider each patient's seizure characteristics, the types of seizures, the potential side effects from medications, interactions that they may have with other medications that they are taking, and ultimately coming to a decision for the right medication. Many times, a patient may not respond initially to that first medication, so there may be a combination of ASMs that would be used. So therefore, it becomes even more important to balance the potential benefits with the side effects of the medicine. So ASMs are meant to be given on a daily basis to prevent seizures from happening. However, in those emergency situations, we have rescue treatments for prolonged or clusters of seizures, such as oral tablets, rectal gels, nasal sprays, injections. These often come in the form of a benzodiazepine. These are prescribed by a health professional to be used in case of an emergency. So what happens when someone has been diagnosed with epilepsy, with a seizure disorder, and they've tried medications but failed? Then we may define drug-resistant epilepsy as a failure to become and stay seizure-free with an adequate trial of at least 2 anti-seizure medications. And at this time, when someone exhibits drug-resistant epilepsy, the chances that that next medication is going to make a substantial difference in reducing their seizure burden becomes lower and lower. And that way, it becomes even more important for us to consider non-medication therapies to help halt seizures. There are many different non-medication therapies available out there. One that's available is diet therapy. You may have heard of ketogenic or modified Atkins diet therapy as a treatment for difficult to control seizures. And I think of diet therapy almost like a medication as well. We have a diet therapy clinic here at UCLA, but it is multidisciplinary with dietitians, and it does require close lab monitoring and close monitoring of the diet as well. So next, for drug-resistant epilepsy, we consider epilepsy surgery as a potential treatment to stop or cure someone from their seizures. As of now, epilepsy surgery is one of the only known potential cures for epilepsy, as opposed to medications which may only prevent the seizures from happening. But in preparation for epilepsy surgery, we undergo what's called a pre-surgical evaluation usually what's done at a comprehensive epilepsy center such as UCLA, which is capable of performing multiple diagnostic studies and offering multiple different types of surgeries for a specific patient. At or after or during the pre-surgical evaluation, it's really important that we have shared and multidisciplinary decision-making, both with the neurologists, the epilepsy specialists, neurosurgeons, as well as our radiologists and neuropsychologists. We have a whole team of specialists to help guide the workup for epilepsy surgery. Then, after multiple discussions, some additional testing may be indicated, or a choice of surgery would be discussed ultimately with the care team, including the neurosurgeon. Just a little bit about seizure first aid. I think it's always important to talk about what to do in case of a seizure emergency. I've taken this poster from a patient advocacy group, the Epilepsy Foundation, which are available online also to share for anywhere you go. But in general, I think just going step by step, and when you recognize a seizure, it's important to stay with the person until the seizure has passed or until they've come back to themselves, back to their neurologic baseline where they may be able to take care of themselves again. During the seizure, please keep the person safe. Just keep them out of immediate harm's way in case they might knock something over during the seizure and potentially fall on them or harm themselves. The best position to lay somebody is on their side when they're having a seizure so that they are able to breathe without obstructing their airway and to let the seizure pass on its own. Loosen any tight clothes around their neck. We advise against putting anything around or near their mouth for your own safety. For any seizures that last longer than 5 minutes or the patient does not return to their usual state, if there's any injury during the seizure, if there's repeated seizures, call 911. If there's ever any doubt about a patient's safety or well-being, don't hesitate and call 911. Lastly, again, I think I would like to reiterate, please do not put any objects in their mouth, do not restrain. Rescue medications, as I mentioned, can be given if prescribed by a healthcare professional. The Epilepsy Foundation also offers seizure first aid courses for anybody that might be interested. Just another great resource, I think, for recognizing seizures, what to do in case of a seizure emergency. I think anybody who might be around somebody with epilepsy, I think the more comfortable we feel in those situations, I think it overall be for the betterment and well-being of our patients. So that's all I have to present for today. This is our group, Pediatric Neurologists at UCLA. Thank you very much again, and I'm happy to take any questions at the end of the talk.
Thank you, Dr. An. If you would like to stop sharing, then we can bring up Dr. Fallah's slides. Yeah. Perfect. All right. So while Dr. Fallah loads up his slides, I'll do a brief introduction. This is Dr. Aria Fallah. He's an associate professor of neurosurgery and pediatrics at UCLA Mattel Children's Hospital and Ronald Reagan UCLA Medical Center in Westwood. He specializes in pediatric neurosurgery and particularly in epilepsy surgery. Welcome, and we're so happy to have you here.
All right, thank you. Nice to be here. Thank you for the invitation. So I particularly focus on pediatric epilepsy surgery, but happy to speak to you about adult epilepsy surgery, which is also part of my practice, even though my focus is on pediatrics. So I'm going to start by briefly talking about epilepsy surgery in general, and later focus on cavernous malformations in particular. In terms of disclosures, I consult for a company that is not really related to the subject matter here today. In terms of objectives, you want to understand the reason for pursuing surgical intervention for epilepsy, introduce the variety of surgical treatments that are available, and describe the contemporary treatment of epilepsy surgery, specifically secondary to cavernous malformations. So the impact of epilepsy in children is actually quite large. About more than 10 million children worldwide have epilepsy, and of course, many more adults. We know epilepsy, especially in children, is twice more common in developing countries as compared to developed countries. And it's really not just the epilepsy, it's the learning disabilities, developmental delay, cognitive delay, behavioral difficulties, and psychosocial problems that are associated with epilepsy, especially if it's not treated appropriately. There was a landmark study that came out many years ago in one of the top journals that we have, the New England Journal of Medicine, that really showed that by the time the first and especially the second medication fails in stopping the seizures, that further medication trials aren't going to necessarily help. And that's sort of what Dr. An also spoke about. Now, in particular, patients that have a structural brain abnormality, so in this case, cavernous malformations, are even more likely to have persistent seizures despite medicine. So we know very early on that the right answer isn't just using more and more medications. All of these medications do have their own set of side effects, and especially in children, we worry about the long-term effects of these medications. But very quickly, we know that by the time even the second medication fails, that we should start thinking about surgical options pretty quickly. In terms of what we see for pediatric epilepsy surgery, there's a whole host of other conditions. So if you look down here, one of the smallest percentages here is vascular. So this is where cavernous malformations may fall into. So it overall makes a small percentage of the patients that we treat with surgery, but definitely an important consideration for patients that are not responding to medications. We have a whole host of tests that we do whenever we're thinking about a pre-surgical workup. The reason why we have so many tests is because there's no one perfect test. And when it comes to evaluating for epilepsy surgery, you need to be at a center, at least a level 3 or a level 4 epilepsy center, to be able to appropriately work up a child or an adult for epilepsy surgery. And these tests that we do typically involve a video EEG, MRI, PET scan, a neuropsychology evaluation, and sometimes even more than that. So it's a really complex testing that goes on, and you really need input from a large number of people with various specialties and expertise to be able to determine whether or not someone's a good candidate for epilepsy surgery. And really what we're looking at is the more concordant the testing is, if everything really points towards the same area of the brain, the more likely it is that if we were to treat that area, we can achieve seizure freedom. This is particularly very important in cavernous malformations because sometimes the cavernous malformation could be a red herring. Maybe that's not where the seizures are coming from. And that's something that we see from time to time, that just because there's a structural abnormality, it doesn't necessarily mean that removing that abnormality will stop the seizure. So testing is much more complex than just having a structural MRI study. And epilepsy surgery in recent years has been really expanding. So we are now thinking about this even earlier and exposing children to less and less medications, and even adults. You may not know this, but the average delay in getting an adult to epilepsy surgery is 22 years from the time of their seizure onset. So definitely a protracted course for many people. But we're working on being able to offer these treatments earlier in life. And sometimes when we cannot do a curative operation, we can do a palliative operation. What that means is an operation geared towards seizure reduction as opposed to seizure cure. And I'll briefly touch on that as well. And nowadays, we have minimally invasive approaches, we have novel approaches and targets, and more tailored treatment, which I'll talk to you about as well. So in terms of pediatric epilepsy surgery, this is our armamentarium. We have quite a few operations that we offer, from diagnostic surgeries where we may place EEG electrodes inside the brain, resection. So this is where most of the surgeries for cavernous malformations will fall into, typically some sort of lesionectomy, which means removing the structural abnormality or the area around it. Ablation surgeries, I'm going to briefly talk to you about the role of laser therapy, which is a minimally invasive option that we are now offering for some types of cavernous malformations. And in situations where the seizures may be too broad, there may not be a single place where the seizure is coming from, or if they're generalized, we may use neuromodulation strategy. So these are epilepsy devices. So these are implantable devices that are going to reduce the frequency and sometimes the severity of the seizures, even though they don't necessarily result in seizure freedom. We have a landmark study, especially in the pediatric side, that came a few years ago that said once the seizures don't respond to medication, if we were to randomize patients to surgery versus ongoing medical therapy, that patients that have medical therapy are going to fare worse than the ones that have a surgical operation in terms of stopping their seizures. And it wasn't just a seizure freedom benefit, it was improvement in quality of life and improvement in behavior as well. So why is there such a reluctance? We know we're in epilepsy surgery, even though it's pretty effective, it's been around for a long time and it's super safe, we still treat such a small proportion of patients that can benefit from epilepsy surgery. And there's a lot of reasons why. Actually, even so in the community, sometimes doctors, neurologists, or internists may not refer patients because they say that the frequency of seizures is too low. We know that any frequency should not be tolerated if you have a surgical option, because you can be cured of seizures. And that could be the difference between being able to drive or not, or being able to swim or not, or some of the activities that really require you to be seizure-free. There's misconceptions about presuming that, epilepsy surgery will fail. If you think about it, these patients, families have been through this where, the medications haven't worked, so they may think that surgery may not work also. And these are some of the other barriers to referral. And there's also from the families and the patients that come and do get referred, there's this overall fear of brain surgery by many, different reasons, assuming that it won't work and so on. So there's a lot of barriers that we have to overcome, but we know, the medical community knows, the epilepsy community knows that, again, some people that have seizures that are more difficult to treat with medications can actually be cured with an operation. And we've known this for quite some time now. So in terms of cavernous malformation, many of you know this, but what it really is an abnormal cluster of dilated blood vessels in the brain, typically caused their problems by either seizures or hemorrhages. And depending on where that is, can be associated with neurological symptoms. They affect about 0.5% of the population. And in the pediatric population in particular, they more commonly present with epilepsy as opposed to hemorrhage. The symptoms there: seizures, headaches, neurological deficits, and sometimes hemorrhages. Diagnosis is made typically by MRI, which is the gold standard. And typically it's the symptoms that prompt imaging, unless you have a gene mutation. And sometimes you may, based on the gene mutation, obtain the imaging before any sort of symptoms. This is what it typically looks like on an MRI. It has this popcorn appearance on T2, and this is what it looks like. So this, for example, is a cavernous malformation that's sitting in the right temporal lobe. And the right temporal lobe, so on these images, everything's flipped. So the left side of the image is actually the right side of the brain. And in this location, this is very close to the hippocampus, which is the it's the hippocampus controls memory in the brain. So to treat this lesion, one option is through a open surgery, which I'll show you. But nowadays, we can treat this in a very minimally invasive fashion, which I'll show you in just 1 second. This is another patient that has a cavernous malformation in the temporal lobe here, where he underwent a typical standard craniotomy and resection, where you can see this part of the brain was removed. Obviously, there's a path to get to this cavernous malformation, so we have to go through some brain tissue to get there. But I do want to show you, going back to that first patient, that we can now use a probe. So this is a laser treatment. This requires a tiny skin incision. So it doesn't require a craniotomy where we lift up an area of bone. Tiny skin incision, a laser probe gets placed right into that area that I showed you was abnormal. And then we use thermal energy, so heat energy, under the guidance of the MRI to create a lesion. A lesion is this area of, we're using heat to destroy the abnormal cells, here being the cavernous malformation. And this blue and yellow area is sort of the area where we're causing the damage to stop that cavernous malformation from being able to generate seizures. And the benefit of this type of surgery is that there's really no downtime. Typically, if you have a laser ablation, you can even go home the same day. Now, we typically keep patients at least for 1 day in hospital, but it's not entirely necessary to stay even for 1 day. So here, for example, is a child who had a laser ablation, and you can barely even see the incision there. You have a hard time finding the incision. So in a minimally invasive fashion, you can essentially have this treated and be home the same day for dinner, if not the next morning for breakfast. So this tool has really helped us to be able to treat some of these. Now, other times you may see a giant cavernous malformation. Now, this is a young child that we treated, and you can see this is a very large cavernous malformation. This is typically only found in the pediatric population, not so often in adults. But this, for example, is not a surgery where we can do minimally invasive, because if you were to put in probes and try to use heat energy to destroy these cells, it would result in a very large area of tissue injury, and that can cause swelling and other problems. So for this, typically we do open surgery. We have a lot of technology available to us to be able to visualize exactly where that abnormality is. So this is looking inside the brain in 3D. This orange blob here is where the cavernous malformation is, allows us to very precisely approach the brain and preserve as much function as possible, but be able to fully remove this lesion. So open surgery is still required in some situations. And this is sort of what it looks like after surgery, where we've removed the abnormality through a small corridor in the brain. And very briefly, I wanted to talk about, I don't like the term palliative epilepsy surgery, but it's a term that's used in the literature. Palliative in this scenario basically means it is meant to reduce the seizure burden, but not necessarily result in seizure freedom. So in situations where the seizures may not be coming from one particular area, or if they are coming from multiple areas of the brain, or generalized epilepsy, or if it's coming from an area of the brain that cannot be removed because removal of that area may result in an unacceptable neurological deficit, we have many other options. These are 3 such technologies. These are where we can use electrical stimulation to increase the threshold at which point the brain generates seizures. In other words, make it more difficult for the brain to have seizures. So on the left, you see this is technology that's been around for a long time, since the 90s. It's called vagus nerve stimulation. This is a generator that sits in the chest, connected to a wire that is wrapped around the vagus nerve and uses this nerve to send impulses towards the brain. And this works and to lower the seizure burden. DBS stands for deep brain stimulation. This is technology that's also been around for quite some time. Initially used in movement disorders like Parkinson's, tremors, but more recently adapted to be used for epilepsy. So here the electrodes go inside the brain, but the generator goes down wires. All of this, by the way, is all under the skin. None of this is visible from the outside. And the generator, kind of like the VNS, sits in the chest, but provides its stimulation inside the brain. And that, we think, is a little bit more effective. There are no head-to-head comparisons with these different technologies, but we do think when we apply brain stimulation, it's a little bit more effective than the stimulation provided in the neck. This is the latest technology here on the right side, the responsive neurostimulation. The difference with this device is that it's responsive. So what it's doing is it's doing a continuous EEG of the brain 24/7 over time, getting better at detecting seizures. And it has, once the neurologist gets enough data, they can program this device so the next time it detects the onset of a seizure, it can apply electrical stimulation to try to stop that seizure. So this device, the battery life is about 11.5 years, which is much longer than the VNS technology and some of the DBS technology. And this generator sits inside the skull here as opposed to down the neck. The electrodes go inside the brain. These types of surgery, especially the RNS, DBS, and to a certain extent the VNS, they have to be done in very specialized epilepsy centers. But these are good options if a surgical resection is not considered a good feasible option for that individual. Take-home messages: there's an increasing number of children, and I should say adults as well, that can benefit from epilepsy surgery. A surgical resection or an ablation offers a chance to cure epilepsy, and we didn't talk about, if you were to stop the seizures and the epilepsy, there's the potential to even come off medications in the long term. Usually not immediately, but after several months to a year, you may consider even coming off some of these medications that have side effects. And there is this shift towards minimally invasive procedures as well. And lastly, every individual seizures and epilepsy are different and individualized. So treatment decisions are usually made in the context of a multidisciplinary team. We want to consider all the pre-surgical information like the video EEG, MRI, PET scan, neuropsych, and all that before we arrive at a recommendation. That's all I have. Thank you very much for your time.
Thank you so much. We have a very full queue of Q&A. And Dr. Anna's already been typing answers to some of our the questions. So I'm gonna cut to it real fast so that we can try to get some of them answered. Are there any specific triggers that are more likely to cause seizures in people with cavernous malformations? Anything that should be, for example, avoided if you have cavernous malformations?
I think with respect to cavernous malformations, specifically when they bleed more, that is when the seizures may increase or symptoms may increase as well. So, increasing seizures may be a sign of some complication from the CCM. So in anyone with a known history of CCM with worsening seizures, I would definitely recommend maybe addressing with your neurologist and perhaps getting some additional neuroimaging at the time of worsening seizures.
Okay. All right. So anything that might reduce hemorrhage risk then would be a good thing, or increasing hemorrhage risk would be a bad thing. What is the size threshold for cavernous malformation and laser ablation? At what point is laser ablation no longer an option?
Let me just add one more thing to the previous question. One of the very important things specific to cavernous malformation is whenever you have bleeding, you have this hemosiderin ring deposit in the brain, which is basically iron deposit in the brain. And that is very epileptogenic, which basically means puts you prone to having seizures. So, and very important part of therapy is, if it's safe, if you're in an area of the brain where you can do it, is when you're treating this, you want to also treat that surrounding hemosiderin ring. Because if you leave that alone, sometimes we see, the cavernous malformation taken out, but the hemosiderin ring is there, and the person still has epilepsy. Connie, going back to your question, what is the limit? Typically, we think anything less than 3 centimeters in diameter being okay, but it has to do with the location. So, for example, if you're closer to the brainstem and you ablate something that swells up, because you're closer to very important real estate in the brain, that can cause symptoms. So it kind of also has to do with where you are. If you're far away from the critical structures of the brain, you can create a larger ablation volume and get away with it.
Excellent, thank you. And then the follow-on to that was, do you only perform laser ablation on lesions causing seizure activity, or can this be a tool used for lesions in other areas of the brain?
Lesions in other areas of the brain. So it's basically the laser activity is, so the laser we can target really anywhere in the brain. I'm a epilepsy surgeon, so my focus is sort of on reducing seizures. There's been increasing evidence in recent years that this could be a good technique. Sometimes, a lot of times it's curative on its own. Other times maybe something to try, and if it doesn't work, you still have the option of the open surgery, which we have a longer track record with. What I don't know too well, it's not a literature that I follow, is what it does for the overall hemorrhage risk. And there's ongoing studies. Unfortunately, with the hemorrhage risk, you kind of need pretty good long-term data to see how that alters the risk. But in the short term, we're not seeing any increased risk of hemorrhage because of the laser ablation.
Okay. We have a significant number of folks, we think that they're mostly adults though, who have been diagnosed with non-epileptic seizures. And we're wondering what you think of that, of that condition, what is that, and just any insights that you can give us.
Yeah, non-epileptic seizures, we're very familiar with. It can have a large overlap with epileptic seizures as well. I think, broadly speaking, non-epileptic seizures may appear by our eyes similar to an epileptic seizure. The difference being that with non-epileptic seizures, we are not able to detect that abnormal electrical seizure activity occurring in the brain at the time of a non-epileptic seizure. And that way, the conventional seizure medications and treatments that we have for epileptic seizures are not effective in the same way for non-epileptic seizures. So the treatment might be different. But there is a very high overlap. Like I mentioned, many patients, up to a third of patients with epileptic seizures may have non-epileptic seizures as well. So, we take it seriously. Anytime that we're not sure, we try and characterize to the best of our ability. But if we're able to determine that something is a non-epileptic seizure, then the treatment for that might be different, not medications, but maybe more focusing on maybe specific triggers or provoking factors that, make the non-epileptic seizures happen, then maybe avoiding those triggers in the future.
I think one of the concerns that the patients that I've spoken with have raised is the limits of EEG and what it is that EEG can pick up, and could there be something truly happening, but it's just not detectable. Is that a possibility or is not?
Yes, yeah, that is always a caveat to the studies that we have. Like Dr. Fallah had mentioned, no one study is perfect. And, sometimes even our best tools fail to detect what truly are epileptic seizures. And it's very unfortunate. Sometimes patients are discounted because our tools are not sophisticated enough to detect epileptic seizures. But that's why I think it's all the more important to go to a comprehensive epilepsy center with trained epileptologists who know clearly the difference between epileptic and non-epileptic seizures, so that we know how to treat each appropriately and together.
Okay. The question is there a typical type of seizure associated with cavernous malformations? And then the follow-on I'll ask right away is, does epilepsy present differently in cavernous malformation patients?
Broadly speaking, I think focal seizures are the main seizure type associated with cavernous malformations, because as you might imagine, cavernous malformations occur in specific regions of the brain. Therefore, wherever someone's cavernous malformation might be is what their seizure symptoms could also be. Therefore, the symptoms for a focal seizure might be different depending on which region of the brain that is, but generally speaking, focal seizures are the main seizure type that patients with CCMs develop.
I think this is for Dr. Fallah. Are you aware of anything that can help with hemosiderin staining that's in eloquent brain tissue? And for this person, it's been there for a while and is now causing increasingly treatment-resistant seizures.
Yeah, there's nothing, unfortunately, that I'm aware of that's sort of medical or something that we can use to sort of sequester that hemosiderin iron deposit. But I will say, depending on the exact scenario, and this is, again, going back to very important to get a opinion at a large epilepsy center, is sometimes we're able to target that tissue or remove it in ways to preserve function, because the hemosiderin deposit itself has no brain function. Like there's no brain function right there, right? So depending on exactly what the anatomy looks like, sometimes there's a way we can sort of sneak into the brain, evacuate that, and leave everything intact. But yeah, in terms of medical therapy and other types of therapy, I'm not really aware. I don't believe there's anything there that can be used to treat it.
Thanks. Are focal aware seizures as damaging to the brain as other types of seizures?
I think any seizure that's not controlled can be potentially damaging to the brain. I think when it's dangerous is when someone is having a seizure and they're not able to control their own body, or they're not aware enough to, you know, have the wherewithal to be able to find safety. And I think that's where it becomes more of a danger or a risk for any patient with a seizure. But any seizure, I think in general, I think is something that we want to take seriously and treat and prevent.
Do seizures tend to worsen over time in specifically kids with cavernous malformations if they don't receive surgery?
They can. I think specifically for that risk of ongoing complications that may occur with untreated cavernous malformations, and that ongoing hemosiderin staining, as Dr. Fallah was mentioning, may lead to continued scarring and potentially for that seizure focus to be more and more entrenched there.
Yeah. And, I had a slide on this, but it's not necessarily just the seizures. It's the seizures are the tip of the iceberg, right? For children, if their brain is seeing all this abnormal electricity, that prevents them from reaching their full cognitive capacity. So, obviously they're in a child, it's a very critical period of development. They have to form memories, they have to learn things, so this ongoing electricity, this abnormal electricity where the brain's kind of being hijacked, right? It's kind of like pressing the reset button on your computer where you kind of have to figure out where you were. Even, going back to the example of a focal, aware seizure, you're sort of, it takes time to sort of reboot and figure out where you were, what you were doing, and you can see how disruptive that can be. So really, it's not just the seizures, it's everything else. And then the other critical thing is seizures over time can spread elsewhere to the brain. So we have the saying, seizures beget seizures. That really means uncontrolled long-term seizures can cause different parts of the brain that were otherwise normal to now generate their own seizure activity. So if someone is a surgical candidate for a possible, for example, curative operation today, it doesn't necessarily mean that they're always going to be a surgical candidate. Because if we let it go on for too long, we may get to a point where now we have multiple parts of the brain, perhaps the left and the right. And then in those situations, we can still help. We can do things like VNS and DBS and RNS. But again, it's unlikely that we can cure that individual. And we're talking about seizure reduction at that point.
This just personal experience with my own child. When she was younger and had abnormal EEG results, they were less fast to jump on it with anti-seizure meds because she wasn't escalating all the way to seizure. But then when she turned 16 and had the same abnormal epileptiform results, they were like, 16-year-olds need to be on medicine. And I don't know whether there's a difference, if there's a higher tolerance, or if it was just this particular neurologist's idea. Is there a higher tolerance for abnormalities in littles versus late teenagers?
As far as EEG abnormalities go, I think my tolerance is the same for any age. You know, if I see or detect some abnormality, I would like to get down to the bottom of it. You know, it is a little bit tricky when, you know, you meet somebody with an abnormal EEG and, you know, if they're not having seizures, then you might not know exactly what to do with this abnormal EEG, but then that risk, that kind of ongoing abnormal electrical activity, you know, may in itself, if they're not clinical seizures, but that abnormal activity can still disrupt the normal learning and development networks that are important for a growing child. So, you know, an abnormal EEG, I think I would kind of take seriously at any age. I don't know the specific kind of details about, you know, your daughter or kind of what those abnormalities might have been, but, you know, it's always a case by case basis too.
And we have, and as you've seen in our population, we have children who have one lesion that's causing epilepsy, and then we have children who have hundreds of lesions. And my daughter falls into closer to that second category, which makes everything a little bit more complicated. Someone else asks, how do you define when someone is having a breakthrough seizure versus someone having a failure in their medication? In other words, when do you make the decision to change their meds versus just increasing the dose?
That's a really good question. That's a hard decision to make too. I don't always kind of separate a breakthrough seizure from a failure of medications. I think my general treatment strategy for any medication is, you know, we try to adjust the dose to the point where the seizures are adequately controlled. In general, I guess what I would consider a medication failure if we really get to an adequate dose, meaning a moderate to high dose based on that patient's age or weight. And if it still is not sufficient in controlling seizures, then I think I would consider that a medication failure. But if, for example, we're at half of the maximum dose of a medication and someone has a seizure, I might not consider that a failure, but maybe a breakthrough seizure, and we might be able to adjust that medication a little bit further to get better control.
Are you aware of any particular triggers for seizures? Heat sensitivity, they mentioned, inflammation, certain foods, supplements are the things that should be avoided.
Yeah, I think triggers are hard because they're so unique to an individual. I think the most common triggers that I see for seizures are sleep deprivation, infection, getting sick, or missing medication dosages. I think those three are probably the most common ones. I think the modifiable ones, definitely, if you remember to take your medications, you're doing your part to prevent the seizures. You know, getting adequate sleep, good sleep hygiene, definitely is important. And, trying to avoid getting sick as much as possible, within a reasonable, measure too.
I'm, we're starting to run shorter on time. I actually had another question. Responsive neurostimulation, how long has that been used? Is that brand new, or has it been out there for
Yeah, it's been around for almost a decade and a half. Initially was in part of the clinical trial, but it's been at least, I want to say, don't quote me on this, but about 7 or 8 years where it sort of has had FDA approval around that time.
and
So go ahead.
I was just going to ask if it's been used in patients with cavernous malformations, or is this reserved for other disorders?
Yeah, good question. Probably because cavernous malformations, those affected with cavernous malformations make up a very small proportion of the overall epilepsy population. I anticipate it's going to be very few, if any, but I will say there's no reason to think that it would not work. Because really we kind of this regardless of the etiology, if we know we have a good sense of where the seizures are coming from, we have a good probability to be able to reduce it. And sometimes, even if it's sort of generalized, there's strategies we can use with the responsive neurostimulation that will work. And I don't think having cavernous malformation as opposed to something else will necessarily mean that that individual may not do as well or will do as well. Over time, we'll get that data for sure, but as of now, it's going to be very few, if any.
And for DBS and VNS, is that the case as well, that CCM patients should do as well with those
Yeah.
technologies?
Yeah, just as we haven't, I'm not aware of any study where we've sort of separated out. So we would kind of code the same likelihood with all these devices.
Okay. That's very heartening and good to know. I know, everyone wants a cure, but if that's not possible, then having some palliative options that are beyond what medication does is a good thing.
I will make a comment too, because so many individuals affected by this may require ongoing MRIs that our current technology, whether it's VNS, DBS, or RNS, are all MRI compatible, which means you can get MRIs going forward. It doesn't preclude you from getting them. So in the past, that wasn't the case, but now we're at the point where we can get it. So
I have one last question that I like to ask, which is, what gives you hope? What do you see coming down the pike that really gets you excited and gives you hope?
I can go. I mean, again, I'm more on the epilepsy side, but as a surgeon, I've seen remarkable differences we've been able to make in everyone's life. Epilepsy is a very isolating condition by itself. There's a lot of stigma associated with seizures and epilepsy, and unfortunately, we're not getting our treatments that are pretty effective out there, and being able to help more and more people. So I am hopeful that we can lower some of the barriers, being able to offer this. Unfortunately, these technologies and these expertise are not as available widely across the country. There's pockets and there's states that have more access to this. So I do want to see a future where we have our treatments more readily accessible, and some of the newer things like laser ablation, being able to do these things more minimally invasive and really helping families. And we made that a comment earlier about, a focal seizure and is that as bad or not? We should be hoping for no seizures. There's a huge difference in quality of life between even one rare seizure and no seizures. And we should be always striving for no seizures as much as we can.
And Dr. An, do you have anything that gives you hope?
Yeah. I mean, a lot. I very much again appreciate the opportunity to interface with advocacy groups such as Alliance to Cure, and be able to talk to y'all in this space, outside of a clinic room, and hopefully, improve the outreach and awareness for these treatments that are out there. working with colleagues such as Dr. Fallah, who are really experts in their respective fields, and being able to bounce off ideas and really try to push the envelope forward for treatment for seizures, is definitely, a huge motivation for us to be somewhere like a comprehensive epilepsy center. So, we appreciate the opportunity, and yeah, any sort of more outreach and marketing and kind of just getting the word out there we can do, is all the more great for us too.
Excellent. Excellent. Thank you. Thanks to both of you. To the audience, I just want to remind you that in the chat right now is the link to the support group if you'd like to go visit it. And also that this webinar will be available on our YouTube channel probably in about a week after we clean up the closed captioning. Dr. Fallah, Dr. An, thank you. I learned a lot, and I'm so pleased to be able to offer our community this information as well. Thank you for your time and for your expertise and for what you do for our families.
My
Have a
pleasure. Thanks for
My
having me.
pleasure. Thank you.